Good afternoon, everyone, again. Please join me today in welcoming our speaker for the day, Dr. Zernicke, a professor of orthopedic surgery, kinesiology, and biomedical engineering at the University of Michigan. Dr. Zernicke began his career with a PhD in biomechanics and anatomy from the University of Wisconsin, after which he held several faculty positions in the Department of Kinesiology at UCLA. He later joined the Department of Surgery and Kinesiology here at the University of Calgary, where he served as Dean of Kinesiology from 1998 to 2005. Before we dive into today's presentation, I'd like to share a memorable moment that highlights Dr. Zernicke's adventures, courtesy of his colleague and friend, Dr. Benedict. When Dr. Nate was coordinating Dr. Zernicke's move to Calgary, he invited him for a winter visit, complete with a classic Canadian skiing experience. On their first chairlift ride, Benno and Ron rode together. They reached the top, Benno raised the safety bar, and they both got off. On the second ride, Dr. Zernicke rode by himself, and this time he did not realize that he needed to lift his feet off the footrest and was unable to open the safety bar in time, almost resulting in an unintended return ride down the mountain. I believe this Canadian experience was so enjoyable that it convinced Dr. Zernicke to make Calgary a significant part of his academic career. With that, I'll turn it over to Dr. Zernicke for his talk titled Biomechanics of Human Performance, Musculoskeletal Adaptation and Injury.
What? No, yes. Testing, 1, 2, 3, 4. Actually, that was the first time that I ever was on a chairlift. That was, anyhow, I had an impoverished childhood, but no, we did a lot of cross-country skiing, but we never had the downhill. Wisconsin, where I grew up, it was basically, not much hills and mountains, not like Switzerland. But thank you very much for the invitation to come here. I'm very, very pleased to be here. I'm seeing some, obviously, many new faces, but also some faces that are familiar from time in the past. And this year I have a sabbatical, so that I'm going to be coming here more frequently, I hope. And we've got some collaborations ongoing, so that will be continuing. So I just wanted to today give you a little bit of a rapid overview of some of the things that I've been involved with and where we are right now in terms of some of the work at Michigan. So in terms of the projects, all right, that's not gonna work, so we'll go with this. That's not gonna work. Do I need to do it on this one? This one? Let's use this. Okay, thank you. What I was going to do is just indicate that one of the things, emphases that I'm going to be emphasizing today is a bit of collaborative, multidisciplinary research, which is absolutely essential, in my view, in many, many people in terms of how we move forward and make new discoveries. And this is something that I published back in 1983, before many of you were born, but basically looking at how do you bring together biomechanics and biochemistry in terms of synthesis for coming up with new ideas. And I'll just briefly go through each of these. University of Wisconsin-Madison, as was indicated, is where I did my graduate work, and at UCLA, and then also University of Calgary, now University of Michigan. And in each of those, I was privileged in order to have stimulating environments that were really a collection of mentors, colleagues, and students, multidisciplinary, and allowed me to move into many different areas. And I just wanted to mention about Dr. Roberts, Dr. Elizabeth Roberts, who actually passed away in January. She would have been 104, but she was still reading papers in molecular biology. She was unbelievable. But what I was able to do at Madison was to look at multi-segmented intersegmental dynamics. And I'll show you a couple examples of where that became important. And essentially what the dissertation work was looking at hip, knee, and ankle forces in using a soccer kick, but then teaching individuals with feedback, basically at a slow, medium, and a fast velocity, and how do the different joints interact as you continue through that speed. Then basically what we've got are at UCLA, the mentors and collaborators, Judy Smith and Reggie Edgerton were some individuals. Reggie was in muscle physiology and Judy was in neuroscience. And there was a lot of work that was going on in terms of bringing together in a common laboratory environment, as you have in HPL here, where you're bringing people together and having multiple disciplines. Bob Greger was a biomechanist and Art Bayless was a biochemist that was working with us. I'll say more about Dave Butler, who was at the University of Cincinnati, and I'll show you some of the work that we did when I did a sabbatical there. And then there's a host of students, hundreds, and I just pointed out a couple of them here in terms of students and postdocs at UCLA. And this is a group with Yosh Setaguchi and Fowler and Oppenheim with the Child Amputee Prosthetics Project. And I'll give you an example of how we use biomechanics to look at clinical interventions. And this was a group with Klaus Schneider, who was from Germany and was a postdoc with me, and we collaborated with Esther Thielen, who was one of the international acclaim as developmental psychologist and developmental. Basically, how do you develop motor control as an infant? So I'll talk a little bit about integrating biomechanics and neuromotor control, Child Amputee Prosthetics Project, infant movement dynamics and motor control in the first year of life. Just as a comment here, Esther was able to convince 4 families who had just had a new child that they should bring the child in once a week for a year. So this is, and they committed to that, and they did that. So that every week, the child came in of the 4 families, and they had EMG, they had motion capture, they had all of these things going on. And we looked at the development of reaching and grasping and locomotion in the infants, Klaus Schneider and I and Esther. And then you'll see how I also did some work with connective tissue and how that work started with patellar tendon rupture as one of my PhD students who was very interested in weightlifting, was also a physics major, and also he was an Olympic lifter. So he had, in terms of this particular tendon rupture. So Child Amputee Prosthetics Project, UCLA was a capture or a magnet for children from Mexico, from the Southwest US and various other places, hundreds of individuals, young children who had had congenital amputations, loss of limbs, absent limbs. So above and below the amputees are which we were looking at primarily. And we looked at various things, you know, the solid ankle cushion heel, which is typically used for these children, versus what we were developing was an energy storing foot. So that essentially this is what people are talking about a lot in terms of various prostheses with Paralympics. And then proximal focal femoral deficiency, which I'll tell you a little bit about. So with PFFD, this is a very short femur, and the ankle was where the knee should be. So it's a very short limb on one side. And typically the orthopedic surgeons were asking, should we do, and I'll give you the examples, assign if you take the foot off and fuse the knee joint, what's there, so that they're basically an amputee there, or should we do a Van Ness rotation plasty, which is cut through the femur, turn it, and then use the ankle as a knee. And I'll show you what that means by that. So Van Ness rotation plasty and sign amputation. The basic question was, so what do we do? What's the best for the child? So this is one that has had, for instance, a rotation plasty, and you can see the length of the tibia on the normal limb, and then on the other side, basically where the ankle is about where the knee should be, because it's been a fusion of the femur. So this is one of the children that basically you can see how very short on the individual's right femur, very short. And then basically the notion is do you then cut through the femur, fuse the knee, and rotate it 90 degrees or 180 degrees or not. So and this is now with the sign amputation, and you can see where the fused knee joint is, and the ankle has been taken off, versus a Van Ness rotation plasty, and where the foot is now pointing backwards. And this is with a young individual who has a rotation plasty, and you can see with a prosthesis and walking. So the question is it better? Are they able to walk better? What are the things that are happening there? So when we did studies on this, we found that there was evidence of active knee joint dynamics. which was actually the ankle joint dynamics, but at the knee joint. So they used those, and in fact, significantly lower metabolic costs during walking. So it was to the advantage of the individual to have a knee joint. The sign amputation, one of the difficulties there was that you saw excessive joint moments and powers on the contralateral side. So you didn't see that as much with the Van Ness rotation plasty. With infant limb dynamics, this is the work that I mentioned with Esther Thielen with Indiana University. And the intersegmental dynamics, the first year of life for these 4 infants who came into the laboratories, Klaus Schneider and I worked through to get the body segment parameters so that we could do the dynamics associated with this. So we then adapted this work, and then this is what I hope is going to work with the or not.
Goes about week. It's slow motion. 4-month-old Gabriel seems to be flailing around almost at random.
He's learning how to control the limb and the intersegmental dynamics.
Here's the route his hand takes before he finally gets the toy. But 7 months later, Gabriel reaches out confidently.
He's able to control the intersegmental dynamics and just go straight to the toy. No, we'll get rid of the extra. Thank you very much. And, okay, there we go. And then moving into another topic, this is with the patellar tendon rupture. This is an Olympic weightlifter. And he was in, this is in a national competition. He finished first place actually. And then he had to try for another weight because someone had another chance to beat him. So he went to the next weight upward. This was using in the old days, 16mm high-speed film. This was a clean and jerk, which you'll see. So this was a little over 2 times body weight that he was doing. And in this particular, the second lift that you'll see, this patellar tendon rupture, was 17 times body weight that the patellar tendon withstood prior to the time that it ruptured. And it pulled away from the patella and from the tibia. So this one, there's no rupture. This is just showing you the full lift of a clean and jerk. And it's blurry and so forth, and that's with 40-year-old 16mm film. So that's the clean portion of it. And jerking overhead. So he actually won the competition with this. But the other fellow had a chance to come back. And actually the person that had a chance to come back, he would have gone to the Montreal Olympics because he was the national champion. All right, so that's the clean, successful, and now coming up. Yes, enough of that. So we did the analysis of that, and as it turned out, I mean, we only had the one camera, but it was exactly that side. It was a planar motion. We could do the full analysis. But what we didn't have were how do you then calculate the load here? You've got the moment, but basically you got the center joint. So we needed to have the moment arm. And what was a year or so later, there was an article that was published out of the University of Iowa by Schmidt and colleagues that basically gave exactly, because the mean weight and size of the individuals that were in that particular X-ray study were exactly the same size as this lifter. So we could use as a reasonable approximation to be able to get that. And we could then look at, so standing there, starting to go down, we're releasing some of the load there on the patellar tendon. And then as it builds, as you're basically coming down and stopping and decelerating. And then here, this interesting is basically because the bar is flexible. So that's when the bar actually wobbled up and then came down at the same time, and then he had stopped it. So that was now the 17.5 times body weight. And where this became somewhat, other than just having this a unique instance, is that at about this couple years later, surgeons are trying to find out what's the best ACL graft. And what tissue should we use in order to find and have the best loading capacity for the ACL replacements? And basically, this is the work that I did with the Dave Butler and the Ed Grun and Frank Noyes at the University of Cincinnati on a sabbatical. And the surgeons at that time in the 80s didn't have a way to choose, but they were using fascia lata, they were using iliotibial band, semitendinosus, gracilis tendons, anything in the territory, and using that and putting it in. And we measured the strength of all of those and the stiffness of basically nearly all of them, and found then that the patellar tendon, the 1/3 of the patellar tendon was the only one that really came above and exceeded. The rest of them were all inferior to the ACL. So that had a major effect, obviously, on, and this was a study that Frank Noyes and Dave Butler, Ed Grun and so forth, and we collaborated on. So, University of Calgary. Here we have collaborators and mentors, people that I've learned from, and they've tolerated me in terms of being able to collaborate with them. And some that I'm continuing to collaborate with Dr. Nate and Walter and Dave Hart and Steve Boyd and Raylene Reimer with some of the studies with high capacity versus low capacity runners in the rats. And so that's ongoing studies. So that's moving forward. But with the work that we did here, we looked at diet, as Walter and others are doing here in terms of high fat, high sucrose diet versus others. And then looking at the exercise effects on bone, post-traumatic joint adaptations, mechanisms of bone adaptation, and I won't go into the fluid flow and the others. I'll just cover and just summarize some of the work. But with the high fat, high sucrose diet, this is work that I did at UCLA. And we found that with the high sucrose diets may cause hyperinsulinemia and decreased renal calcium reabsorption. So in other words, calcium is not being absorbed effectively. And the same thing with a high fat, high sucrose diet. It's pervasive in Western cultures and may contribute to osteopenia. So if you put in particularly saturated fats, increases, and it's the way it's been explained to me is that it's like an intestinal slope formation, which prevents the transport of calcium into the bloodstream in order to be used. And you therefore have decrease in calcium resorption. So both the sucrose and the high fat are factors. And we did several studies with these, with the female straight dolly rats with either low fat, complex carbohydrate, or high fat sucrose diets, and then short term or long term, the lifespan of the animal. So 10 weeks versus the 2 years study. And when you looked at, and the yellow here is the low fat, the red is the high fat. And basically, if you just like the maximum load during bending in tibia, basically it's significantly different. It's lower, significantly less strong bones than those that had the high fat, high sucrose diet. So we found that with long-term, the 2-year diet, basically there was no long-term compensation. You'd think that after a while, the body would start to adapt to this, but not really. And the low fat were basically 60% weaker than, the high fat were basically much weaker. So long-term high fat diet may contribute to osteopenia. Now, on the other end of things, there's some work that we've done, and I've underlined vary because I've been criticized every time I talk about this. Strenuous exercise for children is not bad. What I want to say is that very strenuous exercise can have some detrimental effects. But this was an animal study that we had done with white leghorn roosters, 3 weeks of age, so they're small, running on treadmills, 80 to 70% of max VO2, 5 days a week, and exercise for either 5 or 9 weeks. So within the leghorn rooster, we looked at the tarsal metatarsus, and we put miniature strain gauges on there, and we found that the yellow here is the control, and the red are the runners. So at either 8 or 12 weeks, there's a significantly shorter bone in the runners. A significant effect in terms of those that were doing the high intensity training. And if you looked at the flexural rigidity, the stiffness of the bones, similarly, I mean, it's a significant statistical effect here, but here it's clear, at 12 weeks, you've got the control that are just walking around versus those that are doing the high intensity training. The flexural rigidity is significantly less in those. In other words, overdoing it is not good. So a very strenuous exercise can be detrimental to immature bone. And I just give you an example. There have been other studies that have been done as well, but I use this one from Switzerland. That was a longitudinal study of adolescent female swimmers versus gymnasts. And at very high intensive training during prepubertal and pubertal times, stunted gymnasts' leg length growth decreased their predicted height. And this is Pints and crew there at Journal of Pediatrics. But I wanted to just bring this in as well, some of the work that Heather McKay has done at UBC, looking at, and I put in the upper left-hand corner here, exercise is good for growing bones. But here, she's looking at it around prepubertal and just pubertal times, and that 26% of adult bone is actually gained in the 2 years around adolescence. And in one of the studies that they did with Bounce at the Bell and Action Schools BC, you probably heard all about this in terms of randomized controlled trials within schools. And with this particular study, there was 500 some children, equal male and female. And basically what they found was that the girls and the boys both had positive effects. And this is when they came in the morning, jumped in place. At noon, they did that, and before they went home. All the soccer, everybody's doing the same thing. They're playing basketball, they're doing whatever they're doing, but that in itself, at the particular time, is very, very impactful. So girls get bone mineral content, and boys total were significantly improved as a result of the intervention. Shifting again, focal joint injuries and defects, early bone changes after ACL injuries can lead to osteoarthritis. And this is, you can see here, intra-articular, you can basically see the evernated bone with the probe coming in, and hopefully the video will work. And it does. Watch number 4. She just lost her ACL right there. This is with Norway. And right about there is where you're getting the rotation and the flexion. So what are the consequences? Post-traumatic osteoarthritis. The data from Sweden that they've done longitudinal studies commonly leads to osteoarthritis, articular cartilage degeneration and loss, and early bone changes take place with OA progression. And this is work that we did here. This is with a canine model. This was 12 weeks. And this is with ACL transection on one side and the contralateral side being the control. And you can see the greater bone mineral density here in those on the control side versus the osteoporotic changes that are taking place with the ACL injury. And here just showing you a portion of that, where basically you can see the normal distribution of bone versus the highly porous bone within 12 weeks after the injury. And this is some of the work that Steve Boyd and others have done in terms of the finite element analysis. So post-traumatic OA and bone adapts quickly after an ACL injury, as early as 3 weeks and advanced potentially by 12 weeks. OA prevention may require early intervention, and basically you can quantify post-traumatic vascular response in bone, which we did with laser. And then also, even as within humans now, you do pharmacotherapy, mechano or shock wave therapy, and biologics used in order to then stave off the development of osteoarthritis. So within mechanisms of skeletal adaptation, bone cells respond to strain or deformation related phenomena. And I'll talk mostly about the strain gradients rather than the strain rate and frequency and magnitude. So strain gradient, this was another Rooster model, which was now 1 to 1.5 years, so adults, exercise versus sedentary, treadmill running, and then using the number of cycles that the folks in England, Flint Rubin and Lance Lanyon had indicated in terms of where you can get a significant effect in terms of loading. And then looking at the histological work on this. But we did implanting of miniature strain gauges on the tarsometatarsus, on the anterior, lateral, and medial surfaces, and then looked at the strain distributions. So this is the neutral axis during mid-stance. So this is in the compression, and this is in maximum tension as the bending takes place during the locomotion. So anterior compression, posterior tensile, and then here is the region I'd like to emphasize. This is where I would call it strain gradients are taking place. So creating is related to periosteal activation. In other words, a lot of bone was being developed right in those regions related to that. So here I try to draw out, if you take a bone and you're bending it, so you've got compression, you've got tension, you've got the osteocytes, you've got the canalicula, you've got bony line cells, but basically, as you're bending it, there's going to be fluid flow, which is going to then influence the cells, which stimulates them to produce additional matrix, additional cells. I mean, not cells, but in terms of bone matrix. So, strain gradients can be very important. Now, just a few words about Michigan in terms of collaborations. And one of the people I'll highlight here is Ken Kozlov, who came to Michigan the same time I did, had done his PhD there with Steve Goldstein, who was on the upper left-hand corner. Very famous bone biomechanist. But Ken has done tremendous work in all of these areas. And one of the works that we did was to look at wearables and looking at something that our our sports medicine group came to us about hockey, and particularly with goalies, about femoral acetabular impingement in ice hockey goalies. And what are the worst movements for that? In other words, what causes that? Is there something that we could do to intervene, either strength and conditioning or something like that? So this is looking at the development there that you can see in terms of either osteophytes that are forming here and so forth. And basically it's pain. If you look and you have a survey of NHL or top elite university goalies, 65% of them are going to say that we've got really painful hips. And part of that is really due to a lot of the impingement between the acetabulum and the femur. And this is something that we then published. So this is now, what we did was several of the goalies from Michigan, what we do is do the XNs, do the complete suit there with the IMUs, the inertial motion units on there. And then they go out on the ice and everybody's doing it. You didn't have to be in a laboratory in order to do this. You just went out on the ice. So that basically, and I'll come back to this, but then they did primarily focusing on, in the lower left, on the A would be the butterfly motion. And this is one where they would then stand and stop and internally rotate. So those are the two movements that we're really focusing on. And these give you a little bit of an idea of, what the goalie was doing. All right. And what we found was that the butterfly versus the stopping motion, that in terms of really the impingement, the potential is the stopping was almost double in terms of the potential for impingement. This was almost triple in terms of the internal rotation that takes place. So I mean, what was on the surface, it looks like, oh yeah, this butterfly, that's really the worst thing that we could do. Actually, it doesn't appear to be that way. So I mean, there's translational work like that allows us to say some things about what may be useful and not in terms of prevention of injuries. This is work that I can't say much about the results because on non-disclosure agreements and all of those things, but for the last 5 years or so, we've been working with the National Basketball Association and the Players Association, because they came to us and they said, we're getting inundated with demand from companies saying, you should wear ours, you should wear our device, put our wearables on, all these things. And players, I can remember one fellow saying to me that, so that means if my acute to chronic ratio is down by 12%, they're gonna dock me $5 million on my salary, because I'm not. And his comment was, well, is this 99% accurate? Is this 100% accurate? Is this 50% accurate? Under what conditions? And what about the sleep? What about all the different variables that are being measured? So basically, we did this in collaboration with Fraunhofer Institute in Germany. And they have, it's like 50,000 employees. They've got sensors, they've got satellites, they've got robotics, and I'll show you one other thing that they did have, which we didn't have set up in Michigan. But this was then looking at the wearables and what was the operation that the NBA said is that if a company would go to a company and say, if you want us to test and check your device and whether you want thumbs up or down, you pay us and we'll do the testing. So in other words, it's pay to play in terms of whether you're going to be actually involved with the study. So this is Rhonda Green, who is with Communication Systems, Benny Long, and then also Nicholas Heath from Fraunhofer, and then James Ashton Miller did a lot of the work with the impact testing and the durability of the different wearables. So if somebody gets hit with an elbow and hits the device, is the device still good? Is it still accurate? Or as one of them was, one of the devices or some of the devices are located on right over the sinus processes. It says, well, somebody goes up for a dunk, misses it, comes down, lands on the hardwood, right on top of that, what's going to happen? So James Ashton Miller did impact testing and looked at this. So he had biofidelic force holes and so forth. So James is up there hooking it up, and I'm lifting things up there, but essentially then dropping it and finding out, is the device still accurate? Is it going to be working again, or what has it done? And obviously what he saw there was on some of the devices that were located directly over the spine, you're going to fracture the spine. If something like that, if you landed directly onto those. So actually all the device manufacturer had to do was move it over about, a couple centimeters, you're over muscle. So you're not going to be doing that. So it had to do with some design changes. And then this is something that the Fraunhofer had. They had a facility that they could put out complete NBA, regular basketball court. They put down the hardwood, and then they could have devices on 5-on-5, full game access, and they had over 120 motion capture cameras that were set up there. So it's already set up there. So basically they collected the data and we did a lot of the analysis associated with it. And that's all I can say. I can't give you the results, but anyway. And this is some work now that's going on with Ken Kozlov leading. And this is where we're looking at both the men's and women's cross-country teams at the University of Michigan. And then we're doing preseason, mid-season, and postseason, and I'll show you what we're gonna be doing. But essentially, we've got over 5 years of data now that we've been collecting. And the idea is how do you then intervene or detect possibilities for stress fractures or bone stress injuries? So this is during the cross-country, during indoor track and outdoor track seasons. So on these, along the axis up here, the AS, that's August, September, October, November, and so forth. So you can see that there's cross-country to begin with, then indoor track, and then the outdoor track. And here are the measures that we're taking on each of those individuals. It's all by consent and so forth. So bone mineral density, the lumbar spine and total hip, and then body composition, BMI, surveys, looking at menstruation, looking at eating habits, nutrition, and then sleep. And then looking here, this is looking at bone formation, and this is an osteoblast, and this is with osteoclast with collagen, so that you can look at the CTX resorption. So what's happening in terms of bone, building bone or breaking down the bone. And then looking at bone stress injuries, so looking at the injury information confirmed by imaging, and then also with symptoms that would potentially change as a result of the training. And they're also collecting, obviously, from their, whether it's a Garmin watch or whatever it might be, what training that they're doing and how much running they're going to be doing at the same time. So in the last portion, I'll just bring up some of the things that we're doing now. At the University of Michigan, in about 2016, we launched what was the Exercise and Sports Science Initiative. So the university has initiatives, and if it, as they put it, gets legs and gets sustainable funding, it becomes a center or an institute. So this was now initially the Exercise Sports Science Initiative, and now it's become a center because the funding is there, the projects are there, and everything is moving along. So this is the Human Performance and Sports Science Center. And this is what we're saying is that we're doing, serving the University of Michigan through promotion and amplification of sports science research and education to generate new knowledge to inform human health and performance. So we have 4 strategic priorities that I'll just briefly comment on. First one is to foster innovative and cross-disciplinary human performance in sports science research. And examples of these are work that we've done with Apple Watch more recently, with over 350 subjects coming through the lab, being tested for max tests as well, looking at their whole characteristics. And we're looking at, we did work with the Oura Ring. So there's several of those companies that we're doing analysis with. And then basically, we're looking at building innovative academic environments focused on human performance in sports science. So this is something that university we were very eager to do this because we had the research side, but we also wanted to do the education side of things. So we now have 3 courses that qualify as general electives for any student at the university. So students in business, and these have no prerequisites. So we go through human performance, technology and data in sports science, and social context in sports science. And here are 2 of the lecturers that we have going there. Rajiv Singh, who's a senior performance and developmental scientist with the Charlotte Hornets and professional basketball, and also working with and part-time in Michigan and part-time down in Charlotte. And then also with Lou Portiazzo, who is now the assistant director of Olympic sports strength and conditioning. So Lou and Harjeev are going to be giving these courses that are coming up. And I just put the one quote up there. I thought it was great. You know, you always pick out the best quote from the students in the evaluations. It's probably my favorite class I've ever taken. I couldn't have come at a better time as I'm starting to think more seriously about what I want to do after college. And this is from a literature and science student. And as part of the education component as well, we've developed formal internships for students. So this one, Alex here is basically an intern who's working with wheelchair basketball, the para sports at the University of Michigan. And as well, he will be going to Colorado Springs to the USOPC, to the United States Olympic and Paralympic Training Center, and working with Jeff Burns, who was a former postdoc from Michigan, who's now head of physiology for the Paralympic team. And then also at the University of Michigan, there's adaptive sports and fitness, where they have several of these adaptive sports, in particular the wheelchair basketball. Another individual, and she's been doing a great job with the Detroit Pistons. So she's an intern working with them as well. So the internships are in place, and we're going to be expanding the internships as we move forward. And then moving into the inclusive community interested in human performance and sports science. And this basically is work that we're really pretty excited about because we didn't show you all of it here, but this is now going to be called the Athlete Innovation Lab. This is in the facility that contains this indoor track, which has actually risers that are on hydraulics, so you can get bank curves, you can do all of this. And it has 22 of the teams at the University of Michigan do their training here. So the students don't have to go to all parts of campus in order to get tested. They can be right there doing their training and come in and do testing. So at the laboratory, whether it's a wrestling team or whether it's a track and field team. So we have student placement that we do in the lab and then also on the field so that they're collecting data and doing the analysis on that, data management, athlete assessment that we're doing, injury mitigation, and then human performance. And then lastly, but not leastly, translating discoveries to the communities of all types and ages and abilities. And here, this is some of the work that we're working with the running community in particular around Ann Arbor and Michigan. And here's one that we're doing with Samsung right now. We're looking at the effects of different tone of skin in terms of the access and the sensors that are being used to detect various photo detectors in terms of what's going on, in terms of various measures that are taken with the Samsung device. This is quite a success story during COVID in particular. That was initially called Impact at Home. And you had students who were taking classes remotely, they weren't going to school, and they weren't necessarily, because they were doing this for hours at a time, potentially. Rebecca Hassan, who's a professor in kinesiology, developed along with many other people in terms of the state, who got lots of funding actually from the government and also from the Michigan Health Endowment Fund, to develop these packaged like 15-minute, 20-minute exercise videos. So that you would just, all right, stand up and do this, get some moving around here. So, and this went out to also Detroit Public Television. So there was over 400,000 views, for instance, per week in terms of these during the time. And it's now continuing in terms of impact at home, and they're also doing an impact at school. So they're taking school breaks, not only by having their physical education, but then also taking a break during class in terms of what, for instance, like Heather McKay had done. And then we're having online and in-person kinds of things in terms of, this is Brad Wilkins, founder of the Nike Plus sport performance lab and lead in the Nike Breaking Two scientific team. So just one of the examples of what we're doing with that. And I think that's, unless you want to take the QR code. These are the folks, some of the folks that have helped me to actually work with all this stuff and all the other people and collaborators that I've been privileged to be able to work with. So I'll stop there and thank you very much for your attention. Yes. Hi.
Hello. I have a question on the strain gradients that you showed on the bone. So were those, did you find uniform strain gradients or did you find a strain gradient that changed over the cross section?
Okay, the question was, are they uniform strain gradients? I don't know, do I need to repeat the question for the Zoom or not? Okay, good, I won't have to do that.
Oh, yeah, no, really.
So that, very good. High technology. So,
Strategic placement of myself.
all right, I'll come back to the question in a second here. Oh, it wasn't uniform. It wasn't just like straight, from A to B and then a solid ramp up like this. There was variations depending upon the variances that occurred within caliculi and the connections and so forth. Yeah, no, it was, but if you looked at a total section there, you would see that overall, there was a significant increase in those areas.
And so that would be because of the homogeneities within the.
Precisely, yeah. The underlying foundation, so to say, is not homogeneous. So you're going to see some slight differences as a result of that. Good point. Thank you. Okay, no questions? That's all.
I used the patellar tendon rupture example in my biomechanics class, and we do like a free body diagram and calculate, 17 body.
So did you
weights.
get the right result?
Well, I used the numbers from your textbook.
Okay, all right, okay, okay.
So I'm trusting in you, but,
Okay, well,
so. but
actually, it was, I wouldn't say that, but it was confirmed.
Yeah,
If you take a 1/3 of that, it was exactly 1/3 of the amount that ruptured.
well, I guess that's my point, is you can do these very simple back of the envelope calculations that we do, what's the Achilles tendon force when somebody stands on their toes and
Yeah.
you get, 4, 5, 6 body weights of force. And I guess my question is, at the time when you released these data, were people like, oh, yeah,
Very
okay.
skeptical.
Yeah, okay. That's what I
Very
wanted to
skeptical.
ask, yeah.
But I will tell you, I don't know that I mentioned it during the talk, because I'm just rambling so quickly. What the University of Cincinnati group had done was they were able to, and I was told recently that this isn't possible anymore, but there were younger accident victims who had donated bodies to science. So those were the specimens that were tested. They weren't my age. So these were individuals who were young and active, as opposed to those that were older, maybe active, but I mean, it was potentially a significant difference there. And I think that's where a lot of the data that were out there before we came up with this, saying that's like, well, no, that's way, way too high, way too high. But it existed. And I mean, I don't know. And actually, another quick side story, I got plenty of those, so just stop me. I got a quick side story about that weightlifter. And I won't say names or anything, but that weightlifter, he was, he hoped, he had planned, and he would have qualified if he didn't rupture. He would have qualified to go to represent the US at the Montreal Olympics. So he was a good lifter. And he, and actually I can tell you this because he's one of the authors, Frank Jobe was a very famous, he was the one that invented Tommy John surgery and all this other stuff. He was one of the sports medicine orthopedic surgeons in LA. He told me that basically when he opened up the joint, he said it looked like spaghetti. It was just totally, and he basically, I just gathered it together and put it back into place. 3 months after he finished, they finished with the surgery and his rehabilitation, he was doing squats at 300 pounds. And he was beginning to feel pain. And I would say wisely, he decided, because he wanted to still go to the Olympics. But he said, no, I'm not going to do that. I don't say interestingly, but ironically, 10 years later, he was a CPA, but he was still continuing to lift and so forth, not at the highest levels. But a weightlifting manufacturing company, you know, barbells and so forth, had contracted with him to go around and demonstrate as he went around through Europe and through Africa. And he was in South Africa. He did his left knee.
So the contralateral.
Contralateral knee wall. So I don't know if that's genetics or what it is, but I mean, it still was a huge force that was being generated. And he had lifted heavier weights than that, so why that time? I don't have an answer.
If I can just keep going on that. So you show the resonance of the hole bouncing up and down.
Yeah, the bar, yes,
Almost looks like the rupture happens
right at the
again
time.
when but it's kind of it's bouncing down. I guess it's bouncing down, so the force is going
So
up.
it stopped moving down at the same time he stopped moving
Yeah.
down. So everything,
So if
this
anybody,
nexus occurred, yes.
has anybody tried to think about maybe it would be beneficial to have a stiffer barbell? and-
Who's the lifter in the room? I'm not, I'm just,
Or maybe that really impacts your.
I think it's just basically
performance.
the, you know, the material that you're using. What is it, stainless steel, or I don't know what the material is, but basically it's like, it's a bar.
Yeah,
And it's gonna flex with that amount of weight.
Yeah.
I mean, that's a lot of weight, and especially if you're doing it dynamically. Yeah, but that got me more and more interested in connective tissue as well, so then, you know. Yes. So,
Hi Ron, thanks for your talk. I wondered if you could, expand upon strenuous exercise during growth, because, you know, your work showed that dropping roosters from a height, like, actually improved bone formation, so that
Yeah.
would be
Oops.
more strenuous than running on a treadmill in terms of strains and impact. So I wondered
Maybe.
if you could contrast tucking a rooster.
actually, I don't think we didn't do strain gauges when we were doing the drop jumps, as we call them, bending over. No, I'm glad I didn't have to do that. My back wouldn't work. But no, what she's talking about, there was a study that was done where basically you have the rooster and then just let it flop down and it would land. So you basically come in and land and land and land. So you might do what, 200 of those? So you're doing drop jumps. And that wasn't bad for bone. So the question then becomes, and I don't have the answer to this, but I mean, when you're talking about, you know, the gymnasts who are doing that with very high impact, the high impact may be at a higher level, is what my guess would be. I don't know if it's an educated guess or not, but it's a guess would be that they're gonna be at higher level than if they just drop down like from a 3-foot bench or something like that. So I don't really have a really straight answer on that. And I don't know how much is too much, other than if you just see the end result. I mean, that's the problem. But I mean, there was clearly you know, in terms of growth trajectories, the swimmers versus the gymnasts, there was a difference. And you look at and I'm, you know, not being judgmental in any way, but I mean, if you look at a lot of the superior gymnasts in the world, they're female gymnasts in particular, they're relatively short. Is that because of the training, or is that because of genetics and the training that they've done, and therefore, you know, they were pre-selected, so to say, to do well in that sport because of their body build? Interesting questions.
I guess I'm more curious about why the running impaired bone growth versus the impacts maybe improving it, like, because often.
And I think it was at the time, I mean, these were like 3-week old, I mean, these were very, very young. So it was when bone was at the most, what shall I say, impressionable, you know, in terms of what's going on. And I think the same thing can be happening with, you know, there's a lot of it. What Heather McKay was saying was that, you know, there's a very potent time where a little bit or a fair amount is really useful in terms of building more bone. Whereas, and she didn't go into the extreme to say how much is too much, but essentially saying that, you know, jump or bounce at the bell 3 times a day on top of what all the other activities that you're doing is very, very beneficial and increases the quality and the amount of bone. But yeah, I don't have a good answer. If someone else does, great, but I don't have a good answer of how much is too much. But I think there is evidence to say that overdoing it whatever that means, overdoing it, can be detrimental in terms of growth. Yeah, there's a lot of work to be done yet. Yeah.
I don't have a question.
Yeah, I would like to make a comment. You know, Ron was dean of the kinesiology faculty for about 10 years.
Yeah.
And during that time, he was responsible for part of this building. At the beginning, when we built that part, we only went up to his level. There was nothing above. But we basically designed the whole thing so that you only could screw on 2 more floors. And Ron did all the fundraising for that part. And then I remember quite nicely a meeting we had when we realized that we had about 4 million missing. And then we discussed what should we do, and Ron suggested, why don't we just build it and see what's happening? And that's what he did, and that's the reason that we have the building that we have now.
No, that was mostly originally funded by CFI, Canada Foundation for Innovation, and we were able to get that grant. But that was, no, but also I would also give a compliment back, because whoever designed this initially had the brains in order to make it so that it would be, you don't have to redo the whole thing in order to add 2 more levels. You know, in terms of what you were saying, you just screw it on. Well, that meant there was planning. There was planning ahead of doing something in terms of where this could potentially go. And now there's going to be one across the street, I hear. There's going to be a new. Yes?
Yeah.
All right.
I just wanted to say you are not just a speaker, you are very instrumental of what is here.
Well, I would say that what I've been able to accomplish is because of people here. This is something that, I mean that sincerely. I'm not just saying that. This is something, every place that I've been at UCLA, Calgary, and out in Michigan, working with people and interacting with them, and people say, well, why haven't you retired? My goodness. And I say, well, number one, I enjoy doing what I'm doing, and they continue to pay me. So it's like, okay, I'm gonna keep doing this. So, and I've got a sabbatical this year, so it's all good. So, anyhow. And who knows, maybe the last sabbatical was with Cincinnati when we did the patellar tendon and all of that work. Maybe there's something great that's gonna come out of this. Yeah, there's so much to do. That's always the good part. It never ends. It just keeps going.
That was the last time you took a sabbatical.
Yeah, 1982. All right. All right, you weren't born, I know. Actually, at the beginning of August, no, then I will be quiet. Beginning of August, there was an American Society of Biomechanics meeting. There was a Jim Hay symposium when we gave a talk there, and Ken Kozlov was there. I gave a talk, and then Dave Whiteside, who did he led a lot of the work with the hockey, but he is now senior performance director for the New York Yankees. So he did after his postdoc. And then also Jocelyn Hafer, who's done a lot of work with osteoarthritis and locomotion. So we did that, and it was great but that week, it dawned on me is that when I graduated from Madison and started at UCLA, that was 50 years ago. It was just like, oh my goodness. But anyhow. All right, I'll be
Now,
quiet.
since you described the past quite well, what will the future?
What's the future? Hey, that was the same one that the McCabe group said the same thing. And there's gonna be a paper that's going to be coming out.
2 parts.
Okay,
The first part, the future of biomechanics. And second, the future of multidisciplinary research.
well, the second one is easy, in my view, because it's going to continue. And it's going to expand, and I think it's going to become even more multidisciplinary. And I say that because of the work that we're doing now in terms of whether it's with AI, whether it's with machine learning, all of these different elements, and using big data in terms of looking at things, and then using big data, which I would suggest is one of the future things, because I'm sure they have it here in terms of personal health personalized health, where you're basically looking at treatment specifically for this person rather than this person. So I mean, you're tailoring it to that individual, whether it's a runner, whether it's whoever it might be, a cancer patient, that all of these things, and how do you then uniquely identify what are the things that are best for this individual? And I think that's where we're gonna be able to become more and more accurate in terms of what is being proposed. But I would suggest, you know, whether it's with artificial intelligence, with the big data, and there's so much that has to be done in terms of standardization of data pools. I mean, there's just massive amounts of data. We had a meeting with the strength and conditioning and the athletic trainers of most of the teams in Michigan and all the folks in the room. Basically, the big question that they had is that we are drowning in data. We have so much, you know, all these wearables are collecting and they're just, and some of them just said, well, we just put them on the shelf because I don't know what to do with all of that. How do I use that in the training? What do I do? What do I do tomorrow for John Holash so that he can run faster? I don't know. But I mean, these are things that, can we work with that? How can we work with that? How do we get more individuals? So I think that with biomechanics, I mean, even when I said, you know, 40 some years ago, biomechanics, I was just saying at that time, biomechanics and biochemistry, that you need to get multidisciplinary and focused. And with that, you're going to be able to then come up with other approaches. And that's what I found here when I was here, as well as, you know, whether it's UCLA or Calgary or with Michigan, is that the multidisciplinary teams they're outstanding. I mean, it just gives a stimulating environment and also perspectives that I wouldn't necessarily come up with when I'm talking with someone. It's like, oh, I never thought of that. So, you know, it brings new focus and a renewed focus on things. So I think the multidisciplinary, of course, you know, you can prove me wrong, but my view would be that multidisciplinary is going to continue to be a factor in terms of science. The single scientist working on a bench, and that's it. I don't think that's reality anymore. In almost every place that you go, there's really multidisciplinary kinds of laboratories, interdisciplinary kinds of work. So I don't know that I have an easy answer, but I think the amount of information that needs to be uniquely generated for individuals to make a positive impact in terms of whether it's their health, well-being, or performance is enormous. Yeah, that has to be done. And that's something that, you know, how do you do that? Is it wearables? Is it data that are coming in? Is it feedback? Is it all of those things? So I'm just rambling here, but I don't have the answer. So I just keep talking, but, no, it's a very good question. And it's a very pertinent question. And we're gonna, as I said, actually, the four of us who gave that symposium, that's one of the jobs that we're supposed to actually, Catherine Boyer, who is the editor of Journal of Applied Biomechanics. She's waiting for our manuscript, which is overdue, so we better get working on that. But this is a manuscript that we're going to be doing and pulling in and kind of saying, where's the field of biomechanics going in the next 5 years, something like that. But we shall see.
Any other questions? Not, then let's thank Dr. Zernicke.
And thank you.
Next week on November 7th for Patrick Milner's talk, who is in master's student. And we'll be talking about modeling the effects of AFT shoes on metatarsal stress, a finite element approach.